Hello, everyone. This is Michelle Vickers from the Alabama Department of Public Health. I'll be your moderator today for Significant Findings. I just want to make sure that everybody can hear me.
We can hear you.
Great,
Yes, we can hear you.
thank you. And we're right at a quarter after the hour, and looks like we have a good group of people here, so we'll go ahead and get started. Of course, we wanted to thank everybody for joining us for our session. We want to send a special thanks out to CSTE and the NSSP Community Practice, and of course, Cowena Consulting for helping us pull this virtual symposium together. I'm very excited, and I hope that everybody learns as much as we would do in person. So it was great this was able to come together considering the current situation that we're in. So very excited. And we'll go ahead and go from here. I don't have my camera. I do apologize. So I will be sending the hi sign at our 2-minute warning for our guest speakers. And I will introduce you right before it's your opportunity to speak. There are no objections. Okay, I'll take that as a good to go. All righty then. I am your first speaker actually, so I will go ahead and introduce myself. Again, my name is Michelle Vickers, and I am representing the Alabama Department of Public Health. And you can go ahead and go to the next slide for me, please. And just a really quick bio about me. Since I am introducing myself, I will keep it quick. I am the Public Health Research Analyst here for the Alabama Department of Public Health. I've been with the department since 2011. I've been doing analyzing and researching health data for about 15 years. I earned my Bachelor's of Science in Business Administration from Morgan State University, and I have my Master's of Public Administration from the University of Baltimore, both from Maryland. And I'm also the co-chair of the Data Quality Subcommittee as part of the Council of State and Territorial Epidemiologists Facilitated National Syndromic Surveillance Program Community of Practice. So I'm very happy to be invited to be your moderator, as well as your first speaker. If you would like to go to the next slide for me, please. Okay, thank you. Really quickly, I just wanted to put this slide out here and give a little bit background of what we do here in Alabama. Because I am an analyst as opposed to being an epidemiologist, I have a very different perspective on how we find things that may be relevant, and in this case, significant findings, which is the title of our session today. And what I did is we had an opportunity to review our CLI, which is our COVID-like illness. And I basically wanted to inform my division about the rates that we were coming across, and as well as our counts, because I do a lot of counting, and basically that's what I do. I count the beans and I tell everybody how the beans are looking. So this slide here just represents 2 of the analyses that I was able to run to give our department an idea of how the COVID-like illness is looking in the state of Alabama. We have 8 districts, and our 67 counties are divided within those 8 districts. We do have 2 single county districts, which is Jefferson and Mobile, which means they just have 1 county that represent an entire district. And I know that does impact our numbers, so that's why I like to put that out there first, so that we keep that in mind when we're reviewing the analysis that I've provided. And I usually hand it over to our epidemiologists and allow them to draw the interpretations, because as an analyst, I just give the raw numbers and the statistical significance, and then I allow them to interpret it and to do the rest. So that was the first opportunity I had here with our first picture. I have the CLI counts here, and we looked over the district's means, and we wanted to know if there was any type of statistically significant differences within the means of our CLI counts. What we did find out is that they did have a low p-value. So this kind of led us to believe that there was a difference in the number of CLI records that we were getting among the region, which makes sense because of the different populations. So we expected that there was going to be a mean difference and that the difference would be statistically significant. We also did a CLI rate analysis of the variance, and we found out that those rates actually did not vary, which was kind of shocking because we expected that the rates would have some statistical significance in the difference as well as the counts, when actually they did not. So they determined that there was something else that was impacting the CLI rates within the differences of the jurisdictions versus the counts. So that took us to another opportunity to review maybe some other deeper statistical analysis to determine what was driving the rates of COVID-like illness, where it was not really as different as the counts were. So I presented this information, and they allowed us to look further and to see if there was other contributing factors that would impede, or I'm sorry, influence the CLI rate, because it didn't appear to be that it was a difference within the jurisdictions. So if you want to go ahead to our next slide for me, please. So what I did is I took an opportunity to do a covariance correlation analysis of the CLI records against the populations of our different counties. And as you see, we have our 67 different counties represented here. I chose the colors of the counties to represent the jurisdiction that they belong to help give a better understanding of what may be happening, just not within the districts, but also within the different counties that we have. We did notice that there was a positive correlation between the number of CLI records with the county population, which makes sense. That's what we expected. And so there wasn't really anything that jumped out at this particular analysis that said there might be a difference, because this is what we expect. We also did go ahead, and on our second chart, we took a look at the covariance and correlation analysis of the CLI rates against the number of records. And we actually saw that this was not as advanced for a linear relationship. So that kind of went back to our first revisit for the analysis of the variance, that the rate was not really impacted by the number of CLI records, which gave them an opportunity to look further to see, again, what was driving the rate. So I just basically did two different versions of the same analysis to determine if what I was seeing was actually true, so that we can find out what was driving the rate, because it was not the number of records, which was a bit surprising to our epidemiologists. And again, I attribute it to there are some nuances, such as our single county districts. And again, myself being an analyst, I just give them the numbers and I allow them to do the epidemiological determinations and just do the smoothing and do the other caveats that are necessary for presentation. So a lot of my reports are internal, because they simply go up to our higher staff epidemiologists to make interpretations of what the counts look like, which I think is one of the reasons that I was in this position, because I have a different perspective on the analysis. So that was a great opportunity to share my input on exactly what the numbers look like versus what might actually be happening. So if you would like to go to the next slide, please. Another thing that we do here at the Alabama Department of Public Health is that we are very reliant on the Essence DETERT algorithm. What we have done here is we took advantage of the alert system that is built in our Essence, which we actually use on a regular basis to monitor our COVID-like illnesses. What I have here is an example of how our data changed once we identified our very first positive COVID-19 case. That's what the red line, the red vertical line is. As you can see, that there was actually a clear spike. As soon as we detected it, it seems like it was everywhere. And I like to use this as an example of how Essence default algorithm was beneficial for us in the way that we utilize the data, again, being an analyst and presenting this data to the epidemiologists so that they can have a better understanding of what is actually taking place. I brought two slides here because we also looked at the differences of our COVID-like illness against our seasonal corona-like illness versus our ILI versus our pneumonia. And that's what the charts are at the bottom. We stratify them by different syndromes to see if the alert that we detected for our CLI was actually significant enough that there was an issue, or if it was just a bump up because there were other things that were going on as well. So we do take advantage of Essence and the detector algorithm that they offer. And I use that with our own individual analysis of the records that we find and our counts that we find. And we kind of put all that together and then allow our state health officers and our epidemiologists look further, look deeper to see if there's a true anomaly that's occurring. And we use that as an opportunity to make decisions on what's best regarding our districts, regarding our counties, and again, to be able to provide public health information that is usable and that is ingestible. And then you go to the next slide. Yep, and that's all I got. And I just wanted to say thank you for the people who gave me the opportunity to speak to this topic. And I'm open for questions, and we'll save them till the end since I kind of had a very quick presentation. And we do have several other speakers who have opportunities to present their perspective on how they analyze data and interpret it as well. And we'll move right along to Ms. Amy Gandhi from the Georgia Department of Public Health Services. She serves as the lead for viral hepatitis epidemiology team at the Georgia Department of Public Health, overseeing viral hepatitis A, B, and C surveillance and prevention efforts. Prior to this role, she serves as the Viral Hepatitis Prevention Coordinator for the Georgia Department of Public Health for 8 years, and also manages hepatitis C testing activities and hepatitis C surveillance programs. Her prior experience also includes HIV and STD surveillance, prevention, and program planning. Go ahead, Amy, floor is yours.
Great, thank you very much, everyone, and good afternoon. We go to the next slide. All right, thank you again. So today I will be discussing Georgia's efforts to use syndromic surveillance to address our hepatitis A outbreak. Next slide, please. As other states have also seen, Georgia began experiencing a hepatitis A outbreak in June of 2018. And we had 2 distinct outbreaks in our state being seen among illicit drug users and men who have sex with men. And these outbreaks were in specific geographic areas of the state. Between June 2018 and October 2019, we confirmed 789 cases with a 68% hospitalization rate. Early in our outbreak, we began working closely with our syndromic surveillance program to monitor for all hepatitis A-related diagnoses, exposures, and acute hepatitis symptoms. And then we compared the timing of the syndromic notifications to that of traditional notifiable disease reporting, and then quantified the effectiveness of using syndromic surveillance as part of our hepatitis A outbreak response. Next slide. We receive daily data feeds from 135 emergency departments and urgent cares, and daily line lists are sent to district epidemiologists from queries of 5 discharge diagnoses of hepatitis A, acute viral hepatitis unspecified, contact with and suspected exposure to viral hepatitis, and unspecified viral hepatitis with or without hepatic coma, as well as chief complaints of hepatitis A, Hep A, and a combination of the strings suspect, contact, and Hep. A true positive notification was then determined for patients with a laboratory confirmed hepatitis A infection, and a predictive positive value was calculated statewide and also grouped by the 4 outbreak health districts. Next slide, please. Of the 378 hepatitis A-related notifications that were received, there was a predictive positive value of 33% statewide compared to 53% in the outbreak districts. Of those, 64% of the statewide notifications had a discharge diagnosis of hepatitis A compared to 71% in the outbreak health districts. 30% had a chief complaint of hepatitis A compared to 39% in the outbreak districts, and 25% had a discharge diagnosis of acute viral hepatitis unspecified compared to 48% in the outbreak districts. Next slide, please. 33% of the 378 syndromic notifications that we have received were determined to be confirmed hepatitis A infections. Of those, 79% of the syndromic notifications were received at least one day earlier than was reported to DPH by the provider or the laboratory. 7% were received the same day, and 13% were received at least one day after it was reported to DPH. 48 of the notifications were among patients reporting being a contact or having possible hepatitis A exposure. 23% of those were determined to be a confirmed hepatitis A infection. Next slide, please. So in conclusion, using syndromic surveillance based on discharge diagnoses of hepatitis A and acute viral hepatitis unspecified and a chief complaint of hepatitis A have the best ability to capture hepatitis A infections, especially in high incidence areas in the state, and should be prioritized for follow-up by district epidemiologists for early detection of these infections. Using syndromic surveillance as part of our hepatitis A outbreak response was beneficial in the early identification of cases and allowed for our staff to initiate early investigations, identify contacts, and quickly implement prevention measures to prevent further spread of the infection. Our data shows also the need to target emergency departments and urgent cares that were not immediately reporting suspect or confirmed hepatitis A infections to the Department of Public Health. Next slide. And thank you very much for inviting us to speak today, and I look forward to any questions that you may have later. Thank you.
Thank you, Amy, for an excellent presentation. Our next speaker is Dishka Ramani. Dishka is the Syndromic Surveillance Data Analyst at the Wisconsin Department of Health Services, where she performs analysis and to inform data collection, ongoing surveillance, and reporting. She has a Bachelor of Science in Public Health Sciences from the University of California, Irvine, and a Master's of Public Health and Epidemiology from Drexel University. And she is also my co-chair for the Data Quality Subcommittee. Go ahead, Dishka.
Thank you, Michelle, and thank you to CSGE and NSSP for allowing this presentation. I am representing the Wisconsin Department of Health Services and presenting on the development and use of our COVID-19 metrics. Next slide, please. So Wisconsin's initial statewide metrics for COVID-like illnesses and influenza-like illnesses were created in response to the national reopening guidelines and used ordinary least squares regression to present a 2-week trend in the data. This worked reasonably for statewide data, but posed significant challenges for smaller geographies. In response to a need expressed by our local health officials, the State Department's COVID-19 data team was tasked to produce robust metrics at county and regional level that accounted for key features in the data, mainly day of the week effect, daily fluctuations, and small counts, which are all inherent to syndromic data at small geographies. We also found it necessary to align methodologies for CLI and confirmed cases to allow for a direct comparison and assist with interpretations. Next slide, please. Okay. For COVID-like illnesses, we proposed a 2-part indication based on methodology presented in CDC state indicator reports. We used a homegrown CLI definition that aligned with the state's probable case definition used in a traditional surveillance system. CLI burden for the metric is described as the number of syndromic cases per 100,000 in the last 2 weeks. And the burden cutoffs were based on the methodology described by Harvard's Global Health Institute COVID-19 metrics. The trajectory is described as a % change between the 2-week combined with significance testing, and we used a 2-sided exact Poisson test against the null hypothesis of no change. Both measures were then combined into a composite indication with 1 of 5 levels. The very high and the critically high indications you see on the slide are purely based on burden cutoffs and used for communication purposes. Next slide, please. For influenza-like illnesses, we took advantage of the availability of historical data and best practices to present these trends. We used the historical ILI average percent and standard deviations during non-influenza weeks based on CDC's methodology to determine the baseline and threshold values for each geography independently. Then a rolling 3-day average for the percent of ILI visits is used for the final indication. So this allows for direct comparison with our existing state and national ILI measures. And you can see the 3 activity levels on the screen. So low activity is described as the single days average between, well, below a baseline. Moderate is between baseline and threshold, and elevated activity is described to be above threshold levels. Next slide. So both the CLI and ILI metrics are part of our local data dashboard and published on the website. It is updated weekly and combined with metrics for confirmed cases, testing, hospital capacity, and this is to provide a complete toolkit for decision-making at local levels. The metrics are also included in Wisconsin's COVID-19 mitigation guidance for local health officials. And next slide. That's it from me, and you may contact me at this email, and happy to answer any questions. Thank you.
Thank you, Deshka. Our next speaker that we have slated to speak is actually our Dr. Darcy Phelan Emmerich, and she has served as the Chief Epidemiologist at the Baltimore City Health Department since 2015. Her position is shared between the Baltimore City Health Department and the Johns Hopkins Bloomberg School of Public Health, where she has been a faculty member in epidemiology since 2009. She served on the Committee on Informing the Selection of Leading Health Indicators for Healthy People 2030, convened by the National Academies of Science, Engineering, and Medicine in 2019 and 2020. We're happy to have you here, and go ahead, Doctor.
Thank you so much. Good afternoon, everyone. And again, my name is Darcy Phelan Emmerich, and I'm the Chief Epidemiologist at the Baltimore City Health Department, and very glad to be here with you today. Next slide, please. So I'd just like to start by mentioning I have no conflicts of interest relevant to this presentation, and also wanted to list our GitHub website. So our project has a GitHub website where code is available for Project Soon, which stands for Surveillance of Opioid Overdose and Notification. Next slide, please. So the goals of Project Soon in Baltimore City have been to automate the process of conducting non-fatal opioid overdose surveillance, to notify stakeholders when we do have a non-fatal opioid overdose spike or cluster, and we're doing this using EMS data on a 24-hour cycle. And I do want to acknowledge that CSTE provided support for the development of this project in 2017 and 2018. Next slide, please. The way that we conduct these surveillance is we essentially, on a daily basis, look at EMS data with a non-fatal opioid overdose defined as a patient seen by EMS in the field who responds in a positive way to receipt of naloxone. And so what we do on a daily basis is we use StatScan to identify clusters of our non-fatal opioid overdoses in both space and time. Our minimum number of non-fatal overdoses in a cluster is 3, and we have an alert triggered when the cluster p-value is less than 0.4. The reason that p-value is so large is because in Baltimore City, we have about 4,000 or so non-fatal opioid overdoses a year. So that's about between 5 to 15 a day. So we don't have a ton of non-fatal opioid overdoses, so we use that larger p-value to trigger our alerts. And in terms of what is in our alerts, we have in the inset here, a map for you to see. So this is a spatial intensity, quote unquote, heat map of non-fatal opioid overdoses in the last 30 days. This is just an example. With a circle on the map identifying where the cluster is, and the color of the cluster, or of the circle rather, indicates its statistical significance. When we send out the alert, we include this map as well as a table of cluster information that includes the start and end date of the cluster, the number of non-fatal overdoses involved, the number of non-fatal overdoses in that same geographic area within the last 30 days, as well as the radius of the cluster. We also include a graph of non-fatal overdoses in the last 30 days citywide. And we include a heat map table that helps us look at the number of non-fatal overdoses by month, as well as by geography in the city. And we also include a historical map of clusters, just as reference. And so this alert is what we send out to our partners. So next slide, please. So when we have this alert, we send out a report that I just described to an outreach partner, behavioral health provider partner. We send the alert to Bad Batch, which I'll mention in just a moment, as well as to behavioral health providers in Baltimore City. Once the partner receives the alert, they respond with street outreach in the targeted cluster area, assuming there's capacity to do so. And then the Bad Batch app sends out text message alerts to people who signed up to be notified of non-fatal overdose clusters in specific city regions. And I listed the Bad Batch link here if you're interested in checking it out. It's essentially an app that was created by high school students in Baltimore City to identify, basically help people stay alive in Baltimore City and send out alerts when we see non-fatal opioid overdose clusters in the city. It's a really neat tool and definitely encourage you to check out Bad Batch. Next slide, please. So I'd like to thank my colleagues at the health department, as well as our partners with EMS, as well as our partners at the Johns Hopkins School of Public Health, as well as Code in the Schools, Bad Batch, and as well as CSTE funding. And with that, I will conclude. Next slide. Just say I'm happy to answer any questions that might come up when we get to that point of the session. Thank you so much.
Thank you so much, Darcy, for your presentation, and we'll move right along to our next presenter. We have Kelly Bemis, and we are speaking to Kelly from Cook County, Illinois, where she is an epidemiologist for the Cook County Department of Public Health. She manages the Enhanced Surveillance and Informatics Program, and she is also a former CDC CSTE Applied Epidemiology Fellow and has a Master's of Public Health from Yale School of Public Health.
Great, thanks, Michelle. So I'm going to be talking today about how we're using a program similar to what Darcy just described for opioid overdoses for detection of clusters of COVID-19. You can go to the next slide, please. Just a little bit of background on our experience with the pandemic. We had our first COVID-19 case confirmed in late January, but the pandemic really started heating up for us in mid. And by April, the number of reported cases had outpaced our ability to investigate them all. So we were faced with this question of how are we going to detect outbreaks when we have incomplete epi data? And one of the techniques, among others, that we decided to pilot was daily automated cluster detection with SAT-SCAN. This is a technique that we had been interested in for a while now, ever since New York City published how they were using this analysis type on their reportable diseases back in 2016 in emerging infectious diseases. And if anyone is interested, their paper's really great, and I'd encourage you to look it up. For those of you who may not be familiar with SAT-SCAN, It's a free software available online that's specifically geared towards spatial temporal analysis. And I'll just briefly break down the rest of the terms here. Daily is obvious, so the goal here is to perform this analysis as close to every day as you can. But the automated part, I think, is what makes it really unique. So the idea here is that instead of having an epi who needs to open up StatScan, put in all the files, run the analysis, and then review all the results manually, you have a program that's doing that on your behalf. And in our case, that program is R. If you want to go to the next slide for me, please. This just walks you through the general process of what our R program is doing when we run it every day. The first thing it does is import confirmed cases into the software. We're using exact latitude and longitude for our confirmed cases, but since this is a syndromic conference, I did just want to mention that all of this is highly customizable to whatever you might be interested in. So if this is something you want to try to do on CLI counts aggregated by zip code, you can absolutely do that. But for our purposes, we started with confirmed cases. Once the data is in R uses the R StatScan package to call StatScan and actually perform the cluster detection. For this analysis, we're using the prospective space-time scan statistic. I would probably have an extremely challenging time explaining it myself, so I'll just give a very oversimplified explanation. It's essentially looking at different combinations of space and time and determining how many observed cases are you seeing compared to how many expected cases, and then using that observed expected comparison, it's telling you what are the most likely clusters in your data set and then assigning a statistical significance to them. So as Darcy said, in their program, they're using a very sensitive statistical significance threshold, and ours we're using one that's very specific since we don't have bandwidth to investigate a lot, so you can set it to whatever you want. When our program gets the results back and sees that there's a cluster above that threshold that we set, it then uses a package called R Markdown to generate a report with a line list and a map. R can then automatically email that report to either EPIs for investigation or leadership for situational awareness, whatever's more appropriate. And all of our code is available on GitHub as well, so the link there will direct you to that if you're interested in adapting these methods for yourself. You can go to the next slide. This is just a quick example of what one of our reports look like. So heavily redacted, of course. The top has just some basic information about the cluster. Then you have a line list and a map that had we shown you the whole thing, you would see actual case location. So it gives the EPI something to kind of hit the ground running with. And if you want to go on to the final slide. Here's just a summary of how it's been working for us since we started doing this in late June. Between late June and the end of August, we ran the program 52 days. And of those 52 days, we had 10 clusters that were above our significance threshold. Of those 10 clusters, we weren't able to investigate 3. 2 were because they were too big to investigate, so we did share those with our leadership. And 1, we just didn't have the staff bandwidth that day. The other 7 we did investigate, and all of them were verified clusters. So 1 was linked to a confirmed case that came in from out of town and visited several households. 2 were linked to congregate living settings, an assisted care facility, and a college. And then 4 clusters were linked to 2 different community events. So what I think is notable about this is while the program didn't pick up every outbreak that was reported to us during that time, 6 of these 7 outbreaks we were not alerted to through other means. So they were kind of bonus things that we would not have been able to investigate if we had not been having this program running for us. So we do consider it to be a pretty useful tool as an adjunct to traditional surveillance methods. And if you just go to the last slide, just want to share my email address. So if you have any questions, you can feel free to reach out to me. Thanks.
Thank you, Kelly. It was an excellent presentation as well. And we have actually completed all our presentations, and we have a good 10, 11 minutes to address any of the questions that we may have for any of the speakers. If you want to drop them in the inbox, I could read them, or you can actually raise your hand and we can get you unmuted to speak them. Looks like we have a question here for Darcy. Okay, I'll read the question out for us, or did you want to go ahead and, let's see. Oh, there we go. Darcy, can you see your question?
I can. Okay, so question is, what is known about the profile of subscribers to the Bad Batch app? The answer is, I do not know. I'm not sure in terms of the number of folks who have signed up about for the Bad Batch app. They might have that information on their website. And is there an overlap with the local provider community? That is another question I don't know the answer to. And the Bad Batch alert areas in the city are distinct from other levels of geography. So in the city of Baltimore, we have 200 census tracts, and the Bad Batch regions are divided up into 10 different regions of the city. So there was concern that Bad Batch could be used as a way to direct people towards stronger drugs in Baltimore City, and we didn't want it used that way, so we made sure, working with Bad Batch, that the alert regions were large. So the city is divided up into 10 regions. So I hope that answers your question, Lorena. Happy to discuss offline, and nice to see you on this format. We went to school together. Thank you.
Thank you. Great. I appreciate that. And I think we had a question for Kelly, but I think that was addressed to Cassandra through the inbox. She was asking about a link, and that was taken care of. Okay, Howard had a question for Kelly as well.
Do you want me to read the question, Michelle?
Okay.
There we go. I was hoping Howard could come in. Here he is.
I think I'm unmuted. I just wanted to know what you meant by validated clusters. Does this mean going out and seeking the cases, or is there a formal validation process?
So one of the things we were interested, since this was a new practice for us, in seeing was when you get an alert, are the cases actually epi-linked? So that's what I meant by validated. When we actually looked into them, were we able to identify a common thread between all of them, or was it just a coincidence that in that particular space-time area, there was a high number of cases with no connection between them? So in our case, they were all epi-linked.
For years, people had trouble doing that. It's just so interesting to hear that you're establishing linkages. Is this through contact tracing or something else?
Yep, that's correct. So the way we're using this right now is to prioritize cases for contact tracing. Since we can't get to all of ours, we have a number of different prioritization schemas that basically bumps a case to the top of the list. And when they're part of a SAT-SCAN cluster, they get bumped to the top of the list so that we can get every data.
Thanks.
I see that we had a question for Amy. Amy, do you have an opportunity to address a question from the chat box? It says, why do you think there was a difference in PPV statewide versus outbreaks districts? And that did come from, I think that was Cassandra.
Hi, yeah, and I'll actually, I'll give my opinion. I'll let Renee, who's our syndromic surveillance coordinator, chime in as well. So like I mentioned in the presentation, we have specific geographic areas in the state that we sort of declared Hep A outbreaks in. So they had a very high incidence of hepatitis A infections. So I think that's probably why there's such a difference in the PPVs. When you look at statewide versus those specific geographic areas, because we did have a high incidence rate in those areas. And I can let Renee chime in if he has a different perspective from the syndromic side.
I agree. Basically, it's in those outbreak districts, the numbers are exponentially higher. So we're going to, chances are that the PPV is going to be higher there. Yeah, I agree with Amy.
Okay, thank you, Renee. And I have a question here. The questions was for the covariance plots that I presented for the covariance and correlation analysis for the CLI records. We were actually correlating the number of CLI records on our y-axis and the county population on our x-axis. And then for the rate, the rate was on our x-axis and the number of CLI records was on our y-axis. I hope that answered your question. If you had any more, did you want to unmute? Are we good from there? Okay. Okay, great. Let's see. Okay, we have another question here. It was a question for Kelly about the length of time that you use on your study period.
Oh, sure. We use a relatively short baseline period, so 6 days right now. We've talked about expanding it, but our concern was that if we went any longer as testing increased, that the increase in testing would influence the results. I do know that New York is doing this as well, and they're looking at percent positivity clusters, and their baseline period is 21 days. So you have to adapt it to your local data.
Thank you, Kelly. Okay, and Darcy has dropped the link for the bad batch in there, which is great. Okay, good. Do we have any more questions or anything else we wanted to go ahead and discuss really quickly? We have about 5 minutes in our session left.
Michelle, can you hear me?
Yes, Howard, I can hear you.
I'm seeing in the chat quite a few different users of SAT-SCAN. I don't know if there's any other cluster detection methods. And I'm just wondering if people would be interested in getting our heads together over the next couple of days and see how our different usages are similar and whether we might be able to get anything out of it.
Hi, Howard. I think that's a great idea. I know I spoke in my presentation that I depend heavily on the Essence algorithms because it's easy. StatsCan, I tried it and couldn't do it. So that's the reason for me. But I think that if we do have a lot of people who are interested in learning and working towards which calibrated tool is going to work best for their detection, that's something we can definitely get started and work with.
Now, just a moment, the spatial detector, in essence, is a form of the purely spatial SAT-SCAN and can be applied, I think, already to the CCDD categories. So that is something you could do. It's certainly not as rich as a SAT-SCAN tool.
I think you have a fan base. We have a lot of yes, Howard, that's great. We're doing it and we need to figure out how, yeah. So you're right on the money per usual.
Okay, well, Michelle, you should check out that spatial detector there because you might have something for free that you didn't know about.
Oh, and free is always good. Great. Okay, we have a lot of people commenting on it that it's being used and very interested in learning. I think we need to have a whole session dedicated to it, Howard, because you're just so awesome in bringing it all together for us.
I'm not so great with these tools, so I may ask Charlie for advice or somebody else knows how.
Well, I think we're onto something. Okay, great. Okay, we have about 2 minutes left here, and I wanted to just go back and give a round of applause to all of our speakers and thank them for presenting and carving out time out of their day. We also wanted to give a special thank you to the Community Practice CSTE and Calhoun Consulting.
Thanks,
Okay,
Michelle.
it's no problem. I thank you all for joining. If you have any questions, I think we have contact information available to reach out, and we'll give you back 2 minutes of your day so you can prepare for your break and your next session. Thanks, everyone.